and we'll a little bit ahead of schedule, but we'll go ahead and we will shift gears again. We will welcome Jill Stopfer, one of our genetics experts from Dana-Farber, to talk to us about genetic testing and breast cancer risk. There we go. Okay.
Okay. So thank you very much, Dr. King, for including me in this wonderful day of presentations. I am a genetic counselor, as was mentioned, here at Dana-Farber. And today what I wanted to do is kind of give an overview of genetics and how it can be helpful for people both with and without a cancer diagnosis, both for someone with cancer as well as potentially for their family. So just to start, you've seen a little bit about this already, that most cancer is not hereditary. It's really a smaller slice of the pie. But just to define, what do we mean when we say something is hereditary? Typically, what we mean is that there is a gene, an inherited factor, something you get from both your parents, that can be running in the family, that if you inherit this gene in a non-working form, a gene with a mutation in it, that you live your life at a very significantly increased chance to develop cancer. It doesn't mean someone is going to get cancer for sure, but it really has a very specific and significant impact on their chance. So all because of one single gene with a powerful effect. That's generally what we're referring to when we talk about hereditary risk. And the best known examples of these are the BRCA genes, BRCA1 and 2. There's also this category called familial risk. And familial risk can mean you see a pattern of cancer in a family or a pattern of breast cancer in a family. Maybe there's more cancer than you think you would expect just due to chance alone, but it's not because of one single gene by itself. It may be that in some families, there's a whole set of genes, not just one, but maybe the combined effect of 20 or 50 or even 100 different genes, each with a little bit of an impact, but all together creates a profile of risk. And right now, our genetic testing strategies are best for detecting hereditary risk. And that makes sense. It's easier to find strong risk due to a single gene rather than measure the combined effect of many, many genes collectively in their interaction. But it's important to know that sometimes the family history looks suggestive and we can't find the source of risk yet. And it may be that there is some familial risk that maybe one day, hopefully not too far in the future, we'll be able to detect. And then there's this very large slice of the pie called sporadic cancer. And a lot of this may be due to the combined effects of what we've already heard about today, environmental factors, exposures. But another source of risk for most people is actually just the aging process itself. As we get older, over the course of our lifetimes, our cells are making copies of themselves. We're not the same set of cells that we were born with. We've copied many, many times over. And every time a cell makes a copy of itself, there's a possibility that that copying process does not happen perfectly. And my favorite way to analogize this, it's sort of like photocopying or Xeroxing, a page. We know that copy number 500 is going to have more imperfections in it than copy number 20. And so do we. As we get older, we have all accumulated copying errors through the aging process. It's part of our biology. And these errors are often something that you didn't do anything to make them happen. It's just part of our biology. And so sporadic cancers may not have a specific environmental or risk factor that we can point to, and may just be due to some of these random copying errors. So nature isn't perfect. So when we're suspecting that there may be a single gene with a high impact in a family, what are some of the clues that we get from the family? What you see on your right here is a family tree. When we take our family trees, women are circles, men are squares, just how it is. And we indicate cancer in a family. So here you can see there's woman with an arrow here. She is cancer-free, but she has a mother with breast cancer. Her maternal aunt had ovarian cancer. There's a grandmother with ovarian cancer. We kind of look at a family and think, is there more cancer than we would expect just due to chance alone? Are there multiple generations of cancer? Do we see these cancers occurring in people at ages that are younger than when these cancers typically present? And that will depend on the type of cancer it is. So for example, with breast cancer, seeing it diagnosed before the age of 50 is typically considered on the younger side. But for some other cancers that may naturally present at a younger age, that might not be the case. So we're looking for also rare types of cancer in a family. Ovarian cancer is a less common cancer. Things like pancreatic cancer, metastatic prostate cancer, and then also super rare cancers we can see in families like a melanoma in the back of the eye, really rare cancers. These can be clues about the possibility that hereditary risk is present. Seeing a person in the family who they themselves have had multiple cancers, that may reflect their underlying vulnerability to the process. The fact that it's happened once and then it happened again, that may indicate that they have some sort of hereditary risk. And then we also look for the specific types of cancers and think about, are these ones that run together with a particular gene? So for example, when breast and ovarian cancer are in the same family, that can be highly suggestive of genetic risk due to genes such as BRCA1 or 2. So genetic testing, I like to analogize it as a big spell checking process. We're looking at the spelling of the genetic code. And here I have an example of spell checking. So I have a gene on the left, and I've just put the word theater. And theater is spelled correctly on the left, but on the right, you can see there's some sort of spelling scrambling. When a gene is spelled correctly, it provides a message that does something important for the body to protect us from developing cancer. When we do genetic testing, we're not looking for the presence or absence of a gene, but we're looking to see, is the gene spelled correctly? And if there's a misspelling, like you see here, this XQ, you look at this word, it doesn't mean anything. What is THXQ? It doesn't say anything to us. It's the same thing in genetic testing. We're looking for misspellings that would prevent a gene from working properly. And if someone has inherited a copy of a gene with a misspelling, we call it a mutation, or sometimes we call it a pathogenic variant. That is what leads to the increased risk of cancer compared to the cancer risk in the general population. And finding these mutations is very important because it can impact your care. So how can it impact care? Well, here are a number of different ways that it might affect certain women. So some women who have a breast cancer diagnosis who are thinking about what sort of surgery should I be having? Of course, her surgeon will offer only safe choices, but sometimes a safe choice might be a lumpectomy or just a more limited surgery. But if that woman knew that she had a hereditary risk, that meant she had a high chance for seeing a second breast cancer down the road, some women, not all women, but some women may decide to have more extensive surgery on both sides or bilateral mastectomy in order to hedge against getting another breast cancer down the road. So it gives that woman and her surgeon more information to think about in making the best decision. Sometimes there are women who've never had a breast cancer diagnosis who are found to have hereditary risk who make similar choices. They may decide that they want to lower their risks as much as possible and so choose to have risk-reducing surgery. There are women who, through genetic testing, are found to have a higher risk for ovarian cancer. And sometimes the right decision for some women at the appropriate age is to remove ovaries and fallopian tubes in order to dramatically lower their chance. Increasingly, we're seeing genetic testing sometimes affect doctors' choices for targeted therapy or trying to really match the biology of what's going on in this cancer to the best treatment option. and sometimes identifying hereditary risk as part of that process. We know that screening options might change if hereditary risk is identified. So it's already been discussed that including breast MRI, which may not be standard for all women for screening, it may be very important in women with hereditary risk. And also the age at which we start that screening may be very different. For women with hereditary risk, we may start screening with breast MRI at age 25, for example, whereas most women are not starting screening that early. Hereditary cancer risk typically pulls together multiple cancers due to the same gene. So it may be that someone is at increased risk for more than one type of cancer. And so we may find that there's also a higher risk for something, for example, like colon cancer, and it could change the age at which we start colonoscopy screening as well as the frequency with which we do it. So here's an example of a family where genetic testing made a big difference. In this family, we can see there's a young woman who had breast cancer at an early age. She was only 35. And interestingly, if we look at this family history, it's all on her father's side of the family. And it makes the very important point that your father's side matters just as much as your mother's side. There was nothing on her mother's side, so I've kind of left that off. But we see a concerning pattern all the way on her father's side, a couple cases of ovarian cancer, very early onset breast cancer. And so this woman decided to have genetic testing, and she was found to have a BRCA1 gene mutation. And we can see she's got 3 sisters. And so that information was important for her. This woman who tested positive decided to have risk-reducing mastectomy on the other side. And she, at about age 40, she ended up having her ovaries removed to lower her risk for ovarian cancer. And then her sisters had testing. 2 of them were positive and started the high-risk screening. And one of them, despite being in a family with hereditary risk, tested negative. And so she doesn't need to do all of these extra things. And so genetic testing can really help deliver the right care to the right people in the family, making sure those who are at high risk are getting the proper follow-up. But then those who don't need it, despite being part of a family with a suspicious pattern, when it's not necessary, we're not overdoing it. And so here are some genes that we know about that are associated with a high risk for developing cancer of the breast. And when we say high risk, we're typically talking about risk of approximately 50% lifetime chance, or in some cases higher. And so you can see in this list of genes, the BRCA genes, BRCA1 and 2, can increase the risk for multiple forms of cancer, breast and ovarian. But these are cancers here that can also affect men as well as women. Prostate cancer, melanoma, and pancreas cancer can be part of the spectrum. And there are other genes as well. TP53 is a fairly uncommon type of hereditary risk, but associated with a large constellation of cancers for which there is very specialized screening. And then there are some of these others as well that we include in the high risk category. And then there's a category that we call moderate risk genes. And moderate risk, we're typically talking something at approximately a 30% lifetime chance. And these are some examples: CHEK2, RAD51C and D, ATM, BRIP1 is an ovarian cancer, primarily gene thought to be associated with possibly breast cancer risk in the past, but not so much based on most current data. And so when we do genetic testing, we tend to do something called a multi-gene panel test, where we're looking at lots of genes at once to ensure that whatever's there, we can identify in order to do these things: specialize your screening, optimize the chances of finding cancer early, opportunities to prevent cancer, and helping your family. Genetic counselors can help you move through this process by assessing your risk, discussing the benefits and limitations of testing, arranging it for you, following up depending on what the results are, and then helping include your family. I'm happy to answer any questions about my presentation. I know it was kind of fast, so.
No, thank you, Jill. That was wonderful. So maybe just say a few words about, again, these panel that we test for multiple genes now, as you said, and we call that panel testing. How do you counsel a patient as to, which gene should, how many genes should they be tested for? Should they do, the small panel, the medium panel, the big panel? There's lots of questions out there.
Right. And it's kind of it's a great question, and it has a nuanced answer. We do have different panel sizes, and some of it comes to personal choice. Typically at Dana-Farber, we suggest a comprehensive panel that includes genes for all the common cancers that can run in families, because the family history may or may not be suggestive of something that's there. And we've seen with sort of organ-specific testing, only including genes that predispose to breast cancer, only including genes that predispose to colon cancer, that we miss what we call clinically actionable or important findings that may alter the care for you or your family members. But the size of the panel can be this sort of core panel that covers the common hereditary cancers. And we can dial it up too, to include things that are increasingly rare. And so we do talk with people about, what are some of the pros and cons of going big, with some of the larger panels. You can find some more uncertain findings. That's really one of the main downsides of going with a big panel. You might find a mutation in a gene, and that gene was only recently identified. Maybe the specific risks are still being defined. The medical recommendations for what to do about that are still being discussed. And so that can be a limitation. The other limitation, of course, can be that we see these findings called variants of uncertain significance, or a VUS result. And the more genes you look at, the more likely it is that you'll run into a VUS. Most VUSs are nothing more than variable spellings in the genetic code that are just less common ways to spell a gene. So back to I had the theater analogy in spell checking the genetic code. You can spell theater at the end T-E-R, or you can spell it T-R-E, depending on which side of the Atlantic you live on. They're alternative spellings, and they're both fine. In genetic testing, we see variable sequences all the time. We're not all spelled the same in our genetic code. There's a lot of normal difference. And some of these genes are really big. So for example, the BRCA2 gene is spelled with 20,000 different letters. And so there are a lot of different letters you can put here or there that may reflect nothing more than just a normal sequence change. So a lot of the VUS findings that we find are really nothing, and they're most likely going to end up being nothing, and we put them way on the back burner. And then sometimes we encounter a VUS that's a little more interesting, and we kind of struggle with what to say about it, and we want to follow people more closely in that regard.
Thank you. And just one last quick question is, what about insurance coverage? How would a patient know if her insurance will pay for this testing?
So most people who are good genetic testing candidates will have coverage. It gets submitted at the same time that your sample is sent. And we try to help with all of those arrangements. A lot of people don't know that the cost of genetic testing has come down tremendously. And so even for people who don't have coverage for whatever reason, there's a limitation with their insurance, the entire self-pay price is $249. That's it. And then for our families or people who have more limited income, fortunately, the labs have really generous income guidelines. So those who do have more limited resources often find that the cost of the testing is reduced, and we can typically get genetic testing for anyone who wants it.
Great. Thank you. Really important updates there.